Everybody, we'll make a start to this board meeting. A warm welcome to everybody, and a reminder that the meeting is being broadcast online and recorded. The recording will be uploaded onto the ICB website after the meeting, and a version with British Sign Language will also be produced and uploaded. To facilitate that recording and to support anybody using hearing loops in the room, please make sure that you use your microphone when you speak. Just a reminder, this is a meeting held in public, not a public meeting, but we will make space for questions at the end of the meeting from members of the public. We're not expecting any fire alarm tests today, so if the alarm does sound, we will leave the room calmly through the marked exits, so no running and pushing people out of the way. We've received apologies from Vanessa Ford, our partner member for Mental Health Services, from Charlotte Gorn, our Executive Director of Stakeholder and Partnership, Engagement and Communications at the ICB, and we are expecting Jacqueline to arrive a little late, and we know that Mike will need to leave at 12 o'clock. I think that's... And Ruth also needs to leave early. And Ruth needs to leave early as well. Other than that, I think that's all of the apologies. I can declare that the meeting is quorate, so we can proceed. If I could move on to the declaration of interests, and you can see the declared interests are included in the pack of papers. Could I just check that there are no additional declarations of interest on any agenda item that people need to raise? Thank you. The minutes, action log and matters arising from the 20th of September. We've previously circulated these minutes. Are people content to approve them? Thank you. Moving on to the action log, that has been updated to reflect the latest position on the actions. 3 actions have been closed and 2 actions remain open, with those updates scheduled for the new calendar year. If we can move on to my report, and there's a couple of areas that I was quite keen to highlight to the board. The first of those was the celebrations that we had in relation to Black History Month, which is a really key event. And whilst we did a number of events as the ICB, which the report highlights, what I'm also aware is that there was a huge amount of activity within our individual trusts around Black History Month, and a huge amount of engagement from their staff and from the communities that they serve. So a big thank you to our colleagues in trusts for their work in that area. I also wanted to highlight the launch or the celebratory session on HIV. I represent all of the 5 ICBs on the Fast Track Cities initiative, which was highlighted by Amanda Pritchard over the summer as one of the most successful examples of preventative healthcare in the country, in fact in the world. London is on schedule to be the first major global city which will eradicate the transmission of HIV by 2030. That is a major achievement. In fact, we are anticipating we may even do it early, but that is a major success for London. And it was a fantastic event which I think illustrated the model of working together with our communities, with patient groups, and with clinicians in primary and acute settings, which I think is a model for the way in which we could and should be doing preventative work in a whole range of other clinical areas, and hopefully having the same sort of impact that we've had with that. So on that basis, I'm happy to take any questions on the Chair's report, but suggest that we move on to our next item, which is around health inequalities. Sorry, before I do that, I did want to make an announcement in relation to one of the chairs of our trusts. So Sukhvinder has been the chair of Hounslow and Richmond Community Healthcare Trust and Kingston Trust for around 18 months, and sadly she's having to resign at Christmas due to ongoing health issues. But a big thank you to Sukhvinder for her contribution to our leadership team in South West London. John, we're moving on to health inequalities or health equities, which is a driving force for the ICB. It's one of our 4 statutory functions, and I think you and Catherine are going to give us an update on where we are in that work, and I think you're probably going to provide some challenges for some of the people around the table in terms of the role that they could be playing moving forward. So John, I'll let you introduce the work, and then I think you'll be handing across to Catherine.
Good morning, Chair. Good morning, colleagues. Yes, so thank you for asking us to bring something about, I think the initial ask was health inequalities, and to bring something to board in terms of having a conversation and a discussion, and if the opportunity arises, challenge where appropriate. I think it's fair to say at ICB and also ICB level, we've talked an awful lot, quite rightly, about health inequalities over the past 18 months. And that's been very positive, but in some ways we've become understandably focused on the health inequalities funding which has been available in NHS circles, and I certainly understand that. But I think now perhaps is the time and the opportunity for us as an ICB to perhaps just broaden the conversation and the thinking about what we actually mean by health inequalities, healthcare inequalities and health equity. It's a subtle shift of language, but actually I think it helps us be really clear about where responsibilities for different elements of this actually sit. So I've brought with me this morning Dr. Catherine Heffernan, who is our Director of Health Improvement in the ICB. I'll let Catherine introduce herself a little bit about her background. We have a slide deck here this morning. Elements of it are quite worthy, but it's actually easier to do that just than produce a longer paper. And the key elements for me would be in the contents, and we will talk through some of that, probably for no more than 5 minutes, Chair, because I think the request was to have a conversation about some of the contents of this and where we would go next as a board in terms of thinking about our responsibilities in this space. So over to you, Catherine.
Hello, thank you. For those of you who don't know me, I'm Dr. Catherine Heffernan. I'm Director of Health Improvement, as John has said. I'm a public health consultant, and I also work with South London Partnership as the South West London Public Health Consultant. I've been in the system for a very long time, working in regional, national, NHS England, Public Health England, and then which became OHID and OXA, as you know. So I may look young, but I'm not young. So I'd like to start off by saying that we do think of our Health Inequalities Investment Fund, but actually it's much wider than that. And this is why introducing the concept of health equity, which is what the World Health Organization says we should be tackling with. So health equity is the wider umbrella term, and under health equity we have health inequalities, we have healthcare inequalities, which is very much the role that NHS has the gift to do something about, and we also have health disparities. And health disparities are those particular travelling communities, or asylum seekers and other immigrants as well. So there are 3 very distinct pillars of work here, and in order to really improve health inequalities and improve health equity across the system, we do have to work across those 3 pillars of healthcare inequalities, health inequalities and health disparities. So in that sense, it is a programme of work we need to be doing across South West London, which has started. We do have, of course, it as a priority in our joint forward plan. It's also a priority in our ICP strategy, and very, very key there that in order to make that difference, it is a programme of work and not just little projects that we do here and there. And that for me means that there's a role there for primary care, there's a role there for secondary care, there's a role for our community, there's a role there for our community pharmacists, and there's a role for our wider partners such as local authorities and the voluntary sector in working together to tackle those wider determinants of health, which we know is housing, social welfare, education, etc. Key too, though, to making a big difference are the things that work, which is prevention, of course, community empowerment, improving individuals' self-care and self-empowerment, and also to what's key is working together as a partnership for the wider determinants of health. So I'm going to hand over to John, who's going to cover a bit of what our acutes and our maternity are doing, as well as primary care.
So you will have seen the contents which we've outlined on page 2. So Catherine has helpfully taken us through some of the descriptors, because they are important, because we can mix them up unintentionally. So understanding what the difference is between a health inequality and a healthcare inequality is important, because it does mean what we do with our funding actually matters at the end of the day. So that is just to set the scene. So just want to sort of highlight the oversight framework on slide 8. So obviously we've got an ICB board, which we're all present at today, and we have an ICP board, but we've set up a health equity partnership group, which will oversee 3 key programmes of work. So one of the programmes of work is the Health Inequalities Funding Delivery Group, which we'll touch on later on, a prevention delivery group, because so much of what we're doing is based on prevention, whether it's primary prevention or secondary prevention, and just want to flag up the idea that we have a South West London Health Research Collaborative. We say research, but it does include innovation, because when we think about anchor institutions and the opportunity to bring investment into South West London to give better outcomes for our citizens, patients and residents, there is something about building on research, because when we compare ourselves to other systems, we've real opportunities to go faster and further in that particular area of work. So you'll have all seen the Integrated Care Partnership strategy, in particular the Joint Forward Plan, and so much of what we do with regard to prevention and self-management and innovation, particularly around the primary care space, sits very nicely in the Joint Forward Plan. However, I have to say, when I sort of reread the Joint Forward Plan a couple of months ago, I kind of suddenly realised, to my horror in some ways, that there were certain things that weren't in it. So Mike, you've mentioned the Fast Track Cities piece, and if we did a word check against HIV in our Joint Forward Plan, I don't think it's in there. So that's just something we need to acknowledge and understand, and say when we refresh our Joint Forward Plan, that's a piece of work that we bring in. Likewise, while we might be doing some great work about smoking, have we really thought about the alcohol challenge and some of the historical reasons why we're not on that? So we need to go around that particular boy again. So I think the joy of the Joint Forward Plan in having to revise it every year is those areas where you actually have gaps, such as we've identified in the last few months, you can pick up as priorities and put some focus on them. Just to reflect on the Core 20+5 programme, which is very much based on healthcare providers. It does have some value across the wider system, but I think our wider system partners are kind of say to us, look, it feels very health in orientation in nature, and I do understand that. But nevertheless, there's large benefits of a Core 20+5 approach, because the reality is, if you think Core 20, the poorer you are, the more likely you are to suffer from ill health, the more likely you are to die earlier. All of those metrics we commonly talk about. So if we get and deliver really, really good healthcare in South West London, whether it's across the urgent and emergency care pathway, or whether it's in elective care, the people who require healthcare are more likely to be in the core 20 plus group. So by Dane of being a really good system, actually the people in the core 20 plus group get a better offering as a result. Now that doesn't mean to say that there won't be some problems in there in terms of health equity, but we can deal with that. Likewise, the plus 5 group, just thinking about those other disadvantaged and marginalised groups, whether it's the travelling community or whether it's asylum seekers, that we actually have to concentrate and do some work in there. And then of course you've got the 5 key programmes of work, which includes maternity. Elaine will be talking about maternity and the LMNS shortly after my presentation, but you can see some of the work that the LMNS is doing related to maternity. We have talked at length about the work that's going on in mental health, and that in terms of SMI physical health checks. That's as much about the mental health strategy and the primary care strategy as it is about how we do some of our commissioning in South West London. And likewise in terms of respiratory and blood pressure finding, we can align lots of projects that we're doing in boroughs and across South West London to this particular framework. But I would have to say, as good as the framework it does create risks that you have a very, very narrow focus, particularly around the key elements, which means that things like such as alcohol or HIV you might miss as a result. So you always have to be thinking just a little bit wider than one framework. We've captured some of the work of the APC and the clinical networks in addressing health inequality in South West London and some of the work that we're doing. I think the challenge for us is how do we, not just the APC, but providers in general, whether it's acute mental health or community, think a little bit more about the core 20 plus 5 framework. A little bit of evidence about what the local maternity network system is doing aligned to health inequalities. The bottom line is the safer and better we can make maternity care in London, the more benefit it will be for all of the women in our community, particularly those who live in the core 20 sort of catchments, so to speak. So the key thing is that we get our quality and safety right in maternity as part of that. We've key elements, just an update on some of the work we're doing about prevention, community empowerment, and particularly the long-term conditions work. Long-term conditions work and prevention is embedded in the joint forward plan, and some of the slides bring some of the detail on the actions that we're doing. Key areas include self-management, and the self-management piece is much about bringing digital and innovation into play as necessarily relying on traditional methods which require people to deliver these services, and we know that actually workforce is a challenge. So I am mindful of the digital gap and the digital deficit, so we are really careful when we think about digital opportunities to deliver some of our self-management and prevention activities, that we don't actually make disparities worse by people losing out. So those are some of the slides. I won't run through them all because you will have had a chance to read them. Just want to pick up on the Health Inequalities Fund because it is always a topic for conversation because it does involve the opportunity for investment. A couple of quick slides there to say that it's 75% for existing funds and 25% new schemes, but we have discussed this at detail at various levels across the board and some of the next steps. So I'm confident we're progressing well with the Health Inequalities Fund, which will be running, thankfully, over the, next 16 months. So there is some surety there for providers, whether it's acute mental health or our voluntary colleagues, that the funding is in place, and Helen has found a way to be able to commit to that over the next 16 months in very challenging times, which is fantastic. So we're just going through the final steps in terms of getting that investment out to our colleagues so they continue to deliver some of the work. In addition, we're also sense checking in terms of the funding that was delivered last year in terms of the programmes for delivery this year, that people are meeting the targets and expectations that we had set. So that is a quick run through what is a large slide deck with a lot of detail in it, but hopefully that will set the scene for conversation.
Thank you, John. Could I just ask you to say a little bit more about the Health Equity Partnership Group? Because I think that's a new structure and it's one of the key vehicles that we want to use for both this board but also for the Integrated Care Partnership.
So this is the opportunity, I suppose, where we can have those conversations and hold each other to account around some complex stuff, Mike. I'm really clear that from a health perspective, we cannot do this broad piece of work in isolation, and nor should we choose to do so. so that by really building on the opportunities which an ICP offers us, and having a sort of a health inequalities group which is accountable into a board structure, we can stand over delivery of some of the complex programmes. So if we or our partners aren't delivering, we're all cited on it and we can take action in it. So I'm confident that it's got the right level of subject matter expertise in terms of clinical engagement. It's got the right level of operational engagement, but key is that sort of engagement from our local government colleagues in terms of overseeing the programmes of the work that we're trying to deliver to. So it's early days in that, but I'm really confident that that will allow the ICP, not just the ICB, to have confidence.
Just to add to that we do have really good engagement from our Directors of Public Health. And in fact, our Health Inequalities Fund Delivery Group actually meets tomorrow. And very enthusiastic people in that group, very keen to start working straight away and not just have our delivery plan ready for the ICP strategy, but actually get cracking on our programme of work, which means that we will tackle not just healthcare inequalities, but also health inequalities and health disparities going forward. And as John said, this is very exciting to have a health equity partnership group where we can hold each other to account and work together to do something across South West London. There's also too, you'll see a dotted line into Kevin Fenton's health equity group, of which I'm a member, as is our SRO for health inequalities from local authority. So we're very much engaged there with the London work and what's happening within London, and making sure that we're not just benefiting Londoners, we are taking the work that's being done by GLA, etc., into South West London as well, so that we are definitely doing that health equity across the piece.
I think it's really encouraging that we've got our Directors of Public Health from our local authority partners around the table. Really important. James.
So thanks for the presentation. It covers a huge amount of ground, as does this issue. But I'd like just to focus a bit on secondary prevention, actually, because there's a lot that we can't influence in here, but actually as a health body, we can influence the effectiveness of secondary prevention. We know it took a step back during COVID. We know it took a step back for our most deprived communities as well. And we know that looking at some of our long-term condition management, it's most challenging in our most deprived communities. We've set ourselves some quite challenging goals in here around a cardiometabolic care model, about annual reviews of people with long-term conditions. I think my question is, do we have the capacity and the infrastructure, particularly in general practice, to deliver on those aspirations? And if we don't, how can we get it?
John.
So I think there's a lot into that. I don't think it's just reliant on general practice delivery, James. I think when it comes to secondary prevention, making every contact count within a, dare I say, a secondary care setting has something to offer there too. We've had some challenges around that, particularly with bringing in inclisiran and things like that in terms of cholesterol management. So we understand, and I think some of the trajectories are slowly but surely improving, but one of the challenges is making sure we're doing things that we know actually work. And having an evidence base, and going back to our clinicians and saying, you know, there is a clear evidence base for this. We know it's the right thing to do, and how can we help you to actually do it? But I don't think it can just be a primary care piece to do the secondary prevention. This is where the clinical networks come in terms of the APC and how we think about our clinical pathways, and just making sure that when we design a clinical pathway, or redesign in many cases the clinical pathways under the APC, that we think about primary prevention, but also the secondary prevention piece too. Because I think one of the frustrating aspects for all clinicians is we don't make that sort of every contact count. So I know Epsom St. Helier have had conversations thinking about, okay, when we do pre-op checks, is there any work that we can do to support SMI checks and things like that? So those conversations are starting to happen. Now, sometimes we need some technical innovation around that, because if you're sitting in secondary care, you may not know who is sitting on a particular disease register in primary care, and we're not quite there yet in terms of the sort of longitudinal records to do that. But I'm optimistic that if we can persuade each other that we can do parts of work for each other, we might get a better outcome. particularly in that secondary care space where so many people in this cohort are seeing. Information is captured, but it's not shared, and it's not a deliberate that, it's just the way the system is set up, James.
I'd be keen to hear from Nicola on this issue as well, but I think to contextualise it, one of the challenges I've given to John, and he says, well, this might be a primary care strategy issue, is actually the inequitable distribution of general practice across South West London, and that being the start of the inverse care law, where access to primary care is least available in our poorest communities and most available in our most affluent communities, which has the impact of making sure that our affluent communities have access to planned care. Our least affluent communities need to use urgent and emergency care routes, which means that they're being seen later. But Nicola, I'm really keen to get your view on the challenge that James has laid out.
Yeah, thank you. And James, thank you for the question. I think it's absolutely critical question, really, because so that people understand what we're talking about with secondary prevention, we're talking about people who we already know have risk factors, we already know have long-term conditions, and what we can do is do the right things with a real evidence base. We know what works for these patients to make sure that their diseases don't become more severe, more complicated, end up with admissions to hospital. So it's absolutely the right territory to be talking about. And Mike, what you say about the provision of general practice, that's the fundamental basis of it. Of course, it's about all the other things we can do to support self-care and self-management and skills, not pills, and all of those kind of things. It's a huge territory, really, that we really need to focus on, and focusing it on the areas and the people and the populations that have the highest risks and are the least able to manage it themselves, I think is really critical. Did you notice there wasn't an answer in there? Just to say, this is really, really important, and I think we really need to work out how we're going to do it together as a system, because it's not just general practice delivery, but that is really critical to it.
And I do think that we have a structure now and the architecture that we can begin to make that difference, Nicola, but it is about making sure that we seize the opportunity of moving into that space. Could I bring in Callie next?
Thank you very much. It's just a question, really, because the Cancer Alliance, so RM partners across West London, an awful lot of their work is about targeting, outreach, looking at areas of higher deprivation, how we can ensure we are making it easy for people to access services. So, for example, the lung trucks that are being rolled out, RMP and nationally, have completely changed the dynamic of the most deprived populations getting the fastest access to lung cancer services. So just changing the model can make a big difference. And an awful lot of that work so that's the lung trucks, there are liver trucks, there are various other pieces of work that are about really targeting interventions in a way that makes it much easier for people to access. The man van that's been going around Croydon, which was about raising public awareness in communities that have a much higher risk of prostate cancer. So I guess my question is there more we could do to align the work of the Cancer Alliance, so RM partners, with this particular strategy? Maybe it's already integrated and aligned, but we might be able to leverage some of these things, because when people come forward, they may not have cancer, but they may have something else, and it's just about how we fast-track people in a way that's easy for them. So it was just about, are we doing enough to optimise the relationship between the two pieces of work, if you like? That was my question as a specialist member on the board. Thank you.
So in some ways, I'll just apologise that I didn't have that conversation with the partnership before I put my slide deck together, because you've really sort of articulated some of the what seem like simple schemes, but are actually quite complex to get up and running, and the difference that they can make. And actually, when you look at the Core 20+5, and particularly around the respiratory challenge and picking up early diagnosis of cancer, the sort of Royal Marsden, the partnership, is, dare I say it, all over that in many ways, and would look to bring that into the framework, but understanding that delivery there, which is already very good, there has to be a certain element of autonomy from that cancer perspective around that, but that doesn't mean to say we can't do more. particularly when I think we get into the prevention space, Callie, particularly around the smoking work that we need to do. Because that's where I think there is still an opportunity, even though, you know, smoking rates have gone down consistently over the last 20 years. It's great to see that, and that's had multiple health benefits. I think there's opportunities to go even further, because we are still seeing a lot of diseases, whether it's COPD or cancer, which are eminently preventable, if we could sort of do a little bit more in that smoking space. It's almost people feel like the battle has been won, but we've done very well, but we haven't quite won the battle yet.
Just to add to that, is that there is quite a bit of work going on around cancer screening within South West London, and certainly the public health teams are very involved in that and work very closely with the screening leads in NHS England. So there is that work. You might be sorry that you put your hand up here, because I will be roping you in, because there is a lot to be done around the cancer space, and to build on that screening work that is ongoing, because we know that we do have, particularly with our Asian communities, much lower uptake than we would like of cancer screening. And as we know, cancer is cancer screening programs are a fantastic way to prevent cancer from progressing. So the other thing too is we do have the tobacco dependency steering group, program steering group, that's up and running, and it's been running for the past year, and fantastic work has been done across the acute trusts in their terms of outpatients, their inpatients and the maternity units, and that's been linking in very well into our community stop smoking services as well. So a paper of that will be coming to the first meeting of the Health Equity Partnership Group, and thereafter the board will hear about that great work that's going on. So it's I just wanted to add that there is work going on, it's just hasn't been perhaps as visible as it should have been.
I have to say that I think this debate is actually a really good precursor for agenda item 8, which we've got later on in the agenda, because I think it shows, this is beginning to show a whole range of the exciting opportunities. Mike, I know that you had your hand up quite a long time ago, so I'm finally getting around to you.
That's okay, I'm happy to listen to colleagues as well. So two things occurred to me. In terms of the thing that has the biggest impact on health inequalities, as the paper makes clear, it's the determinants of health. So the way that we're structured as a system, we give the lead responsibility rightly to place for tackling that, if you like, on our behalf, and obviously local authorities have a lead role as convener of place to bring a broad group of partners together to try and tackle those issues. But I just wonder whether there's something for us to think about as the board in terms of how we keep a track on that, whether we're satisfied that in terms of our responsibilities as a board for tackling health inequalities in the overall system, how we satisfy ourselves that that's been adequately tackled at place. That was the first thing. And then secondly, so the report sets out the great work that's happening, if you like, in dedicated spaces looking at tackling these issues. But personally, I think we need to more routinely make sure that in the business that comes through here, we routinely identify what contribution the decisions we make is having towards delivering our outcomes around health inequality. So if you look at our board papers, we don't currently do that. You can sometimes go off and have a look at the equality impact assessment and get it there. But given it's one of our 4 overarching priorities, it feels to me like it ought to routinely come through in the advice that we get as a board about whether we're having the right impact. So just 2 things we might think about.
Mike, I think that the last point in particular is one that we really need to take on board. And I do think it should be informing all of our investment decisions, all of our that we make with NHS resources. In regard to the first point, I think, yes, this board definitely needs to be minded of that, but it really sits very squarely with the role of the ICP. And I think we just need to make sure that we're enabling the ICP to have a full discussion in that arena, and that is brought back to this board and informs our decisions really, really clearly. Matthew, you also had your hand up a long, long time ago.
It's okay, Mike. I'm well known for my patience. A couple of points, because I agree with Mike, the importance of this and making sure that it gets reflected in mainstream work as well as specific initiatives, and I was going to sort of give a couple of examples. So just this week, I went to the Brigstock Road Community Hub, which is part of the Healthy Communities Together initiative in Croydon. And if you want to see health inequalities in action, it's places like that that really make the difference, because that is about providing access to services, a range of things to the local population in a way that that local population will access, as opposed to ways that people like me might think that they could or should access it. So I think there are some really good individual schemes that we could start to, explore and share here, and that we might get some good practice sharing from others. It's also about baking it into some of the standard things that we do, as Mike's just described. So, for example, the CDC work that we're doing, we've got this big new hub coming up at New Addington. That's going to make a big difference to the population over there. So I think there are areas where we've got some good work being done, but it's the scale of the challenge, I think, is my final point. And we just had a recent survey done of young people at schools in Croydon, again, from my patch. And unfortunately, the results of that are that they are largely inactive, spend an awful lot of time eating the wrong food, and while smoking rates might be going down, vaping rates are at an epidemic, and that is a problem that we are going to live with going forward, all of us. So there is work that, interestingly, our secondary care clinicians, one of our respiratory physicians, wants to use that work and is now linking with schools leaders in Croydon to try to do some work in schools, because I think from a health inequalities perspective, the link to children and young people is massively important. Otherwise, we're just going to be baking this in for the next 20, 30, 40 years.
Thank you, Catherine. Thank you, John. So there's a massive amount of work going on, isn't there? And to make a difference to any of those three elements of health equity is going to take some time, isn't it? So we all know that. But I suppose my question is, if we're sitting here in a year's time as a board, or 24 months' time as a board, as a result of the work that we're doing, what are the kind of differences that we're expecting in health inequalities over that time?
So, a good question, putting me on the spot. I think I would just go back to our JFP delivery plan and what we've lined out in the JFP delivery plan. We've put some of the detail in there. And then I think we'll be able to point to some hard metrics of outcomes. Now, some of those outcomes are actually processes, to be honest with you. They're not necessarily outcomes, but if you get your process right, you can be sure you'll probably have a proxy outcome. So the JFP will be a key focus in terms of the partnership delivery group, because that's what we've signed up to and that's what we've said we'll endeavour to deliver. I'm also mindful, if not anxious, that new priorities constantly appear and wax and wane over a period of time. So how we understand those new priorities, which may come down nationally or from local region or might be generated within a place, and how we pay attention to those. But we will have to prioritise key areas. We've done that through the JFP. It doesn't mean to say we can't sort of subtly change stuff, but if we're constantly updating and changing everything every year or so, I don't think we'll ever deliver anything. Just on that, we know the value of everything but the price of nothing, or is it the other way around from Oscar Wilde? But a lot of the work we're trying to do in South West London is based on engagement, and sometimes you just cannot count what engagement actually means. So Matthew, you mentioned that community work in Croydon. We've lots of examples of that. Lots of our health inequalities, if not our innovation programmes, are based on reaching out to communities, because if we reach out to communities, we increase their chances of actually accessing healthcare in the first place. And if they're able to access healthcare, they're more likely to have better outcomes with earlier diagnosis. And that goes back to some of your points, Mike. So engagement work and opportunities doesn't feel like a hip or a cataract operation, because it isn't something you can count and it doesn't sit in a waiting list, but it's something you get the benefit over a prolonged period of time.
I think I think there might be an additional piece of work there, which is actually looking at where we do have some hard measures attached to some of the initiatives. So if I look at the amazing work our MP are doing as the Cancer Alliance around some of this early diagnosis in hard-to-reach communities, actually they have a really strong series of outcome measures that they're assessing the programme against over the medium term. So I think we can probably also collate some of those existing ones. Catherine, you wanted to come in, then I will go back to you, James. I know you've been keen to come back in for ages, but just keen to make sure we get some other, get as many voices as possible in this important debate. But Catherine and Zara, can I come to you as well on the community engagement piece?
I was just going to add that basically, as of tomorrow, I would be able to fully answer your question, but off the top of my head, just like what you've picked up, we can see the changes that are happening in our uptake of screening programs, for instance. We can see your changes in our uptake of immunisations. I would like to see this time next year that more of our core plus 20 are taking up NHS health checks, for instance. So we know where our underserved communities are. We know where our underserved individuals are. It's a matter of now making those steps. So we do have some measurables that we can do between now and next year. And then, of course, the wider determinants of health will take a bit longer, but perhaps we could take the initial measure of how many of our institutions will be anchor this time next year or on the way to being anchor, what social value are we putting into the community. So there's a lot of different measures. So it's a bit off the top of my head. We are working on it, but there will be some improvements, Karen, that we'll be able to see this time next year.
And we may also, as part of that, want to be looking at where we have opportunities to incentivise or penalise poor behaviour, where we're not getting good outcomes, particularly around things like vaccinations, whether they're contractual levers that we could and should be using to drive up performance in our poorest communities. And I think that goes across the whole of the primary care footprint, including ophthalmology and dentistry as well. So we could and should be using those levers to drive improvements in health inequalities. James.
Thank you, and sorry to come back in again, but I think my point was the one I wanted to make anyway, but probably is amplified by the contributions from other members. I think my challenge to all of us is, where we know we've got variation in how well we're supporting communities, where we know that some of those challenges for those communities are tractable, whether within health or within wider determinants, and where we know that there is more that we could do. It's what our tolerance is, I suppose, as a board for, firstly, not having I think we need to have a full understanding of where that variation is. I think that can be driven by the population health management processes we've got in each place, but I think we need to have that visibility from my perspective. And then for me, there's a conversation about, if there are opportunities that we feel that we might be leaving on the table to address some of that, some of those equity challenges, how tolerant of that we are. We know that there are evidence-based things we can do around secondary prevention, but also more widely. So I think we should be challenging ourselves, and I think we should be challenging our places to say, how are we closing those gaps? So for me, it does absolutely come down to the metrics, and it absolutely comes down to Karen's point about where we be in 1 or 2 years, and where I think we should be is closing the gap on a number of metrics around equity, health equity, between our best performing and lowest performing populations.
Thank you. Zara, do you want to say? Okay, please.
Thanks, Catherine, John, for your presentation. And John, thank you so much for flagging the importance of good community engagement. Health Watch is always quite keen to share our learnings of engaging with populations who are experiencing health inequalities. I also just wanted to make a comment because we had a discussion at the ICP meeting, one of the meetings over the summer, where we reviewed the outcomes of different groups who had won the Health Inequalities Fund last year. And folks around the table were quite keen that those outcomes and the results of those projects were not just kept in the board papers, but were shared in some kind of repository, so we can begin to learn, what works for whom and under what circumstances, conversely, what doesn't work. And I just wanted to know if there are any plans to share the outcomes of last year's Health Innovation Funds and this existing fund.
I've got a number of plans, but one plan is certainly through the South West London Health Research Collaborative is to try and help projects like that get into the public domain and get into the evidence base. I've always been such an advocator of where there's a lack of evidence, let's create our evidence, but let's get it into the public domain so other people can use it. So there will be a number of different ways coming across, but one we're working on with South London Partnership is to hopefully have a South West London Research Summit in February, March, and that will be a way for people to showcase all the work they've done and the results that they've done. We've recently just appointed to a researcher who's going to be hosted in one of our academic institutions on behalf of the ICB, whose role it is to work with people who've done prevention and public health research, such as the projects you've mentioned, to help them turn it into peer review papers and into conference papers. And I love the idea of a depository or somewhere where we can have it. So that's something that I'll take away and talk with the comms team if there's somewhere where we can showcase and hold that, so people in future when they're wanting to do something can see, because I'm completely agree with you. And there's so much learning. We need to learn from the things that didn't work and why they didn't work as much as learning from the things that have worked.
Thank you for that. I'm going to take one final comment now, so Dick.
Thanks, Mike. Several people have commented on the issue of mainstreaming and how to get this embedded in our strategy. And I agree with Mike's point about how can we bring this to the board. But I just wonder if we need to do, we need to support that with some thinking on showing the financial impact of a lack of equity and a lack of inequalities, because normally people are excluded, end up being much more expensive because they only get healthcare at the last moment. The more we could address that financial issue, it strikes me the more we start to build that evidence base for why there's a core strategic case for this board, let alone the ICP, to shift the balance of our work on healthcare. And I wonder if it might be possible to build in something like that, because the risk of an unsupported bit on a board paper is that it just becomes a bit of language rather than some genuine research that could help us build a case.
I will ask the team to look into that as part of the work that we've committed to around Mike. Mark, you look like you're absolutely itching to come in. Is that right? Have I
suppose it was just going back to the primary care strategy, because that's a catch-all phrase, really, and underneath that I think there's a lot of work going on at Place, as James mentioned, and some really innovative stuff about outreach into people's home, the Brazil model in Wandsworth. And I think there's something about Callie's comments about joining it all up, so that actually as a board we've got a full picture of what is happening in each place and how we are addressing deprivation, etc., in each place. And I think that's really important. Also, just to say, Core 20+5 is a driver for our PCNs to be looking at their local communities and delivering the services. And we do have a lot of health champions, a lot of social prescribing that are outreaching into the communities that we're talking about. So it's just to say that we mentioned the primary care strategy, but I think I know we're planning something in the future with, about a deep dive into that, so that we get a really good understanding of what's going on.
Great. Thank you for that. I mean, I think a really, really rich discussion. I think hopefully, John and Catherine, you feel that you've got enough from the meeting in terms of shaping some of the forward thinking and so on. Clearly some very positive views on things that you're already looking at, and I think some additional areas that we potentially can focus on. Sarah, did you want to say any final words on this?
So, I mean, just that this is obviously a very high priority for the board. I am going to be talking about item 8 later, which I think we just need to link back into this work. It's obviously very, very complex as well, and I do think what we will need to do going forward is get some real clarity over what the priorities are for this board and how we're going to measure our outcomes on this and how we take that forwards, because I think sometimes what we try to do, particularly around public health, and my public health colleagues I know do struggle with this sometimes themselves, is we're trying to do everything, and actually what we might need to do is to prioritise within the kind of what would be the biggest things that we can do together across South West London that will make the biggest impact in the sort of short to medium term, and then build on that. And I think that we need to think through how do we do that and bring that back to the board and the ICP.
Sarah, thank you for that. So we will move on to the next item on the agenda, which is item 6, and this is update on progress from South West London's local maternity and neonatal system. And Elaine, you're going to lead on this item, so over to you.
Thank you, Chair. Good morning, colleagues. As you can see from the papers, this is an update on how the South West London local maternity and neonatal system has been supporting the recommendations from the Kirkup report, Reading the Signals Maternity and Neonatal Services, Kirkup report, also known as the East Kent report. I think it's important to note that this is a snapshot in time of the progress that has been made across our maternity units in South West London. Maternity, quite rightly, is at the forefront of public and national media and public interest at the moment, not just in South West London but across the country, and I think that's rightly so. If we remind colleagues, there's been a significant number of independent inquiries over recent years, starting with Morecambe Bay, then the Ockenden reports, and indeed the ongoing Ockenden investigation up in the Midlands, and then the East Kent report. Many of these reports have started to pull together some similar themes and issues. And this year, earlier this year, in March of this year, there was a new national 3-year delivery plan for maternity and neonatal services. All of them looking at 4 key actions in terms of monitoring and performance, standards of clinical behaviour, team working, and responding to some of the challenges of maternity services with honesty. This report looks at how the local service, the local M&S, has supported our key trusts in terms of the progress that they're making on some of those key recommendations. And you can see some of the innovative and interesting work that's happening across the patch. But I think it's important to say we recognise that there are challenges and issues in South West London, and there is more to do. We'll note that there is going to be a board seminar in future on maternity to look in depth at where we're at and recognising some of the challenges that we have in our progress. I'm happy to take any questions or
Elaine, thank you for that. And I think really important to flag up the more substantial discussion we're planning to have on both maternity, but more broadly women's and children's health as well. Can I check with colleagues if there's any questions? Ruth.
Thank you. So I was reflecting back on the discussion that we had on this last time we had one of these reports, and one of the key discussions that we had was about how we as a board provide ourselves with assurance, particularly around key action area 4, looking good whilst doing badly. And I think we've noted in here that that is where, given some of the CQC reports that we have had since, where there are concerns and worries about performance in the maternity unit. So I think it would be, for the seminar, really important that we explore that issue in more depth, and I'd be grateful if we could think about the best way in which we can do that.
Mercy, as chair of the Quality Committee.
We look at this quite on a regular basis, actually, especially the national targets that were set out, and obviously interrogate what we're doing. I remember from our last discussion, we actually talked about culture a lot in kind of the different services, and especially given the CQC reports and the assurance we were looking at and improvements that are coming out of some of those recommendations. So it is an area that we look at quite closely, and that comes quite regularly to QOC. what it has done in the last kind of last 6 months or so that we are having a look at it. So yes, an area of concern. Nationally as well, I have to say that what we're having in South West London, especially with some of the reports that are coming out, is a lot to do with kind of the national issues with recruitment, retention and all those kind of issues as well. And I noted on some reports, of course, infrastructure as well, about our local estates, in particular hospitals, of course, as well. So yes, an area of concern, and I'm glad that we're going to have a look at it as a wider seminar for the board to consider.
Thank you. So I might as well cough it out about St George's really, rather than pretend anything different. And I think one of the things, because we've been working with Elaine and with the regional office in regards to the St George's maternity unit, and whilst there are undoubtedly some problems in there, I think number one, we have to be clear about the CQC and what they look at. So they look at a lot about risk, and a lot about potential risk, but not always at outcomes. So we can't confuse the two. But one of the things that we've always asked ourselves as a board is, how do we get there and not know? And when we've looked across it, and one of the things that the national, kind of an MSSP, maternity, anyway, they come in to support us, and is that there isn't really any great data that we can look across and know how we could have triangulated if we'd looked really hard, but there isn't actually really good data there isn't really a data set at the minute that is clear that would have helped us. And that is one of the things that they are working on with us, about how do we get data that would actually help us look at that, as well as maintaining the data about outcome. And I think, one of the things that I was quite surprised about is when I said, well, we had the fourth best maternity survey in the country. Ockenden gave us a clean bill of health, or, it was a good report. We thought we could take that as some assurance. They said, oh, no, that's not what the CQC look at. So that's the bit you have to try and get to about what's relevant and what's not. And some of it might not be relevant to the CQC, and some of it will. And I think it's trying to triangulate all of that into how can we track this and know that we're getting to the right place.
I'll come to Elaine for final comments. Oh, sorry. I'll come to you in a moment. Sarah.
Thank you. Sarah from the South West London Voluntary Community and Social Enterprise Sector Alliance. As you know, there are fantastic range of voluntary sector groups working with mothers-to-be as well as new mums in the sector. So I was kind of thinking while you were talking about the different levels at which the voluntary sector could engage. And I mean, from my perspective, the scenario is a bit confusing in the sense that you've got the South West London Children, Young People and Maternity System Board. We also got recently Homestart Saturn on the South West London Mental Health Perinatal Programme Partnership Group. You've got your Patients Experience Forums as well, and I guess borough level, you've got maternity boards as well within each hospital. I know for sure that we've got a rep in Croydon on, Croydon University Hospital. So I was trying to think about how can we maybe make the voluntary sector, representation, if you want, on these boards a bit more cohesive and make sure that they're there around the right table to support you with your efforts. And of course, for things like the seminar on children and women's health that you're planning, it would be fantastic to be involved as well and get some of the groups, in that seminar. But generally speaking, maybe we can have a chat about how we can embed better the voluntary sector, in whatever system there is in place within maternity.
No, thank you. And I think there's lots of opportunities for the voluntary sector, and as you allude to, in some trusts, it's more involved and engaged than others, and we need to be consistent across the patch. Yeah, we'll pick that up and have some conversations. I think you know, Jacqueline makes some fair points. Lots of the issues and lots of the national reports that I alluded to do talk about culture and behaviours, and that can't always be picked up on the data analysis. I spent the afternoon at St George's last week and spent some considerable time with the maternity team, talking to them and walking around and really starting to listen to their issues and actually their engagement in the process in terms of and them understanding actually some of their culture and behaviours and how that's been perceived. And I think some colleagues prided themselves on their outcomes and their inpatient survey, that their patients told them that they had a good experience, but they didn't really think about how they were working as a team and their own cultures and behaviours and how that worked. So, but they're very engaged with the processes that they're going through at the moment and very proud of their service and determined to improve things. And I think there's lots of opportunities for us across South West London and lots of learning of where we've got some more positive behaviours in units and how we've improved those.
Elaine, thank you for that, and I think we're all looking forward to the seminar discussion as well. So that will be forthcoming in the new year. We're going to move on to item 7. Tonya, would you like to come up and join us? I think there's a seat at the far end there that you can take. This item is looking at the Better Care Fund for 23 to 25, and it's about formally approving the Section 75 agreements. Tonya.
Thank you, Chair. So the paper you have today is in 2 parts. The first part is requesting approval from the board to sign the Section 75s, and the second part gives you an update on the BCF review that we are taking on across all 6 boroughs and working on together at South West London level as well. So the first part has asked the board to approve the signing of the Section 75s, which are the mechanism by which we pooled budgets between the NHS and local authorities. The BCS is a pooled budget and focused on supporting people to stay well, safe and independent for longer, and to provide care at the right place at the right time for the right person. So it also has been expanded to support discharge this year. So as a minimum, the BCF has 4 elements. It has the NHS minimum contribution, which is set nationally, which each ICB has to make. It has the improved BCF, which is an allocation directly to local authorities. It has the Disabilities Facilities Grant, which again is an allocation straight to authorities. And the newest one is a discharge fund, which is split between the NHS and local authorities. So the BCF plans are signed off and progress is monitored through health and wellbeing boards, and the latest BSF plans were signed off by all 6 health and wellbeing boards by the deadline given the 30th of June, and each borough has had a letter of approval for the plans from the national team. Due to the value of the Section 75s, the boards are required to agree their signing. Given time pressures, it wasn't possible to present the paper to the Finance and Planning committee before the board. However, the chair of that committee has seen the paper and has approved the paper being submitted today. So the time frame given for signing the Section 75s at a national level is the 31st of October. We have missed that deadline, but the NHS and the ICB is committed to sign all Section 75s by the end of this month. What I would assure the board is the signing of the Section 75s doesn't actually impact on delivery, as most of the schemes are already up and running on our service delivery. So whilst we haven't managed to do that due to various reasons, it hasn't stopped the mobilisation. On that note, I'm asking the board, are they happy to approve the recommendation of the signing of the Section 75s?
Dick.
Just a quick point, Chair. Indeed, there wasn't time for this to go to Finance and Planning Committee. I was very happy to approve it coming here. I mean, the deadlines require it. I'm reassured by seeing that all the health and wellbeing boards have agreed this, and I'm very grateful to Tonya for really excellent background information, which helped me feel more assured. So just wanted to get that governance point clear.
No, thank you for that. Clearly this is substantial sums of money, over £200 million of public funding. Mike, from a local authority perspective, did you want to say anything? I suspect you'll want to say something about the BCF review, but in terms of the signing of the Section 75s.
I think the key thing has already been mentioned, which is they've been signed off by the Health and Wellbeing Board, so we've had an opportunity to satisfy ourselves. I've got no further comments today, Mike.
Thank you. In which case, can I see if there is assent to agree? Fantastic. You've got your approval. Tonya, it would be good to hear now a little bit about the ongoing review.
Thank you, Chair. So all boroughs have been taking forward or were planning to review the BCF in this year. So we thought it was a real opportunity to bring that work together, to share good practice, to look at areas that we could work together on. And I'm very pleased to say that myself and Jeremy D'Souza, who's the DAS at Wandsworth and Richmond, are co-chairing a piece of work looking at the reviews. I won't go through the detail in the paper. You can read everything that's been said there. Some of the early findings have shown that in the work we had a workshop in the end of October, and we showcased the work that has been done to date and identified areas for collaboration, which are at the end of the paper. In summary, I think what the benefit has been today, and I think it's fair to say that we all lost sight a little bit of the BCFs over the last couple of years, particularly through the pandemic. So I think it's really helped local boroughs to have a real more granular understanding what their BCFs are focused at and what they are delivering. In that, it also highlighted some issues, particularly around outcomes and data. But we have made some changes. Some of the boroughs have decommissioned services or have brought more services into the BCF as it seemed to be the right thing. We also talked about what the BCF isn't, and I think there's some not lack of understanding, but actually reminding people what the BCF isn't. So it's not a service in itself, and it's not new money. So it's not an allocation as such. Most of it is linked to services. So at least one of the boroughs, most of the community contract goes through the BCF. So it's not discretionary funding, which we can then decide how it can be spent. To say most of it is linked to services. And there are some very specific conditions that are set nationally around the BCF that have to be met. And I was talking to colleagues this week, and it's definitely an area that nationally they scrutinise at a quite an in-depth level. It's not something that is not scrutinised, that we are meeting conditions. So there is parameters which are closely monitored. But that doesn't mean there's not more we could be doing with BCF and how we can make it more efficient and improve the use of the money and the impact we're having. So we looked at areas that we would like to collaborate on. One of those that came out to the fore was how do we develop an intermediate care model and a subacute model for South West London. That came out quite strongly. Also, how do we start to look at shared outcomes and measurements so that when we're looking across South West London, we're comparing the outcomes that we are measuring the same thing. Also sharing good practice. I'm very pleased to say that Croydon have agreed to run a front runner session next week, which I've invited colleagues for, which is a national pilot that is very much focused on what the BCF is focused on, so that were really good learning. That was all I was going to say. I've been very impressed by each borough, and they really embraced the review and see the benefit. One borough also mentioned that they now feel that their leaders in borough now understand the BCF more than they've ever done before, and actually really supportive about how we can do things differently going forward. So that's all I was going to say. What we'll do at the end of the year is do a write-up, and I'm happy to come back to the board to share that.
Tonya, thank you very, very much for that. And I found the I think pages 16 to 19, which had the place-based summaries, really fascinating in terms of what was found and some of the actions that have been taken and actions that are planned to be taken. I thought that was really rich. Are there comments particularly from place leaders in relation to this paper? I'm happy to take them from anybody, but I thought place leaders might be keen. So James, and then Matthew.
I think the trick with the BCF is to try and simplify really and explain what it's doing in each area and what the contribution is that it makes, and what is unique about commissioning and contracting for services in a joined up way through the BCF in each area. So it's, local authorities can commission and contract for services, the NHS can commission and contract for services. It's what we get differently from doing it together and having those joint oversight arrangements. And I think that's what we need to continue to bring out, because it can get a bit mechanistic, but there is at its heart, there is a very, very important principle, which is about that joint oversight and that pooling of resources. So I think that's really important. One specific thing that is identified in the paper for Sutton, which is an ongoing challenge for us, is how we fail fast and exit things, and that is really difficult, because when we do put support in, the rest of the system sort of evolves to have a reliance on that support, and then actually, if we look at something and say it's not the right area of investment, getting out of it is then very, very difficult, and it's very difficult for the NHS, and it's very difficult for local authority leaders as well, if there's a perceived reliance on an area of support. So I think we need to continue to be very robust about that and develop the mechanisms to do that effectively.
Thanks, James. Matthew, and then I'll go to Mark.
Yeah, thanks, Chair. I mean, a couple of points. From my perspective, one of the key issues with this is about local ownership. There is definite value in sharing, and you get a lot from learning what others are doing and thinking about how you can adopt some of that in your own patch. But a lot of this is to do with what actually works between council, health, and for us, increasingly voluntary sector. It's a big part of what we're trying to do now with provision through the voluntary sector for a number of our BCF schemes. So for me, I think that's absolutely crucial. That doesn't mean to say there isn't learning that you can get from others, and we're very happy to be doing the front runner programme and looking at that. Hasn't solved the world, but it definitely is developing the integrated way of working between health and care, and if we can share some of that and there's some benefit from that, we're very pleased to do so.
Thank you. Mark.
I suppose it's just we've found the review really, really helpful, but the BCF is our integration mechanism. It enables us to take that step forward and align things, and I suppose we should be constantly reviewing it against our review of community services contract that's coming up, and also our winter and our discharge. So I think this is the platform for us to continuously review that investment.
Joe.
Yeah, and I'll just echo what Matthew and Mark have just said. We've reviewed it both at Richmond and Kingston Place committees, and we're due to have a further set of seminars early in the new year. And I'd echo Matthew's point about the voluntary sector there, really leaning into this and see this as an opportunity for them to get involved and make a real difference locally. So, absolutely, we need to make the most of all of this, but we're highly engaged in it in our local places. Thank you.
Thank you. Ruth.
Thanks. Just a quick point. I'm really struck by both the report and the discussion here, the maturity of the conversation. And I just wanted to make the point that one of the reasons that this level of cooperation is so mature is because this has been in place for some time now. And I think we need to recognise that opportunities like this for cooperation need time to bed in. I think this is a really good example. So we need to talk to our masters, the various people who are making decisions higher up that actually need time to embed, because this is the result. And I think it's a really good example of how you can get that balance right between the importance of place, but also recognise that there are sub-regional and national drivers as well. So I'm certainly going to use this as an example of just stop mucking up the system, just give us some time to get on with it, and look what we can achieve as a result.
Ruth, thank you very, very much for that. And I share that view. I think, Tonya, I like the fact that we had a co-chairing arrangement for the review. I think that's been absolutely essential. We're the only part of London that's actually undertaken a review as substantial as this, and I think it's down to Sarah and I to share the learning from what we've found, but also how we did it with our colleagues in the other ICBs in London. I'm going to pass across to Sarah for last words on this.
Yeah, so I do think that's quite important. I think that when this was first raised, and when I first raised it, I think we ought to look at it because it's a lot of money. Because it is £200 million for us in the ICB. I think there was lots of nervousness from local authorities, which I do understand, because there was a worry that we were going to start to withdraw services and money from that pot. And we gave assurances, I think, at that time that was not the intent. And actually, this was about trying to get the best value for both local authorities and the NHS through looking at what we were doing and saying, are we doing all the right things? And I do think that's important. And I think, Ruth, you're absolutely right. It's the maturity of the relationships and the way in which this review has been done together that has led us to be able to do a successful review, and I think should be ongoing as part of the work that we carry on with. I'm not saying nobody's done any reviews, but I know that it has been a lot more difficult in other areas, even to get into the discussion about reviewing BCF, because it's automatically seen as a risk for different parts of the system. And I think it's really important that we share the learning from what we've done in South West London. I'd also like to thank all of the local authorities and the NHS staff that have been involved in this, because actually that's the only reason it has been a kind of successful way of working, and we need to take it forward in that way in the future. So thank you.
Thank you for that, Tonya. I think you've heard a lot of appreciation for the work as well. If you could pass that back to colleagues, because this is a vital part of our business. Okay, we'll move on to item 8 now, and this is not to say that the other items we haven't discussed on today's agenda are really important, but actually this goes to the heart of the way in which we want to do business in South West London, how we feel that we can make a difference. So we have discussed at a lot of length our desire to shift our funding profile away from the acute treatment areas into more preventative and anticipatory healthcare. And we can only shift that funding if we do that in a staged way in order to stop people getting sick in the first place, to reduce the demand upon acute services. This is how we can create a sustainable and equitable health system in South West London. I'm really pleased that we're bringing this paper today. So I'm going to ask Sarah, as our Chief Executive, to present it.
Thank you, Chair. So firstly, thank you to Tonya and Helen, who've pulled the paper together for us. This is something that we identified as a board some time ago, and discussions earlier around health inequalities prevention, community, primary care. How do we actually work in a very different way? This is a prime purpose for an ICB, is to actually deliver on things like inequalities prevention. The only way we will do that is by putting resource into the, I always get confused around upstream, downstream, but at the forefront, wherever it is, it's right up front there. That actually that's where we put some of our resources. I've been in the NHS for over 30 years, and we have been talking about this. We've been talking about putting the resources at the front of the patient journey for all of those 30 years, and we have not been successful in doing that. And actually, part of what we are here to do as an ICB is to support that and to try and make the difference. I do not believe that you can just take money out of hospitals and put it at the front of the journey. We also need to deliver good, high-quality healthcare in hospitals. So what we've got to do is think very differently about how we do this. So what we're saying is that we would like the board, and there is lots of evidence that say that if we do this, we will actually take the pressure off of some of our hospitals, we will have better outcomes for local people. There is evidence that backs this up. But what we've got to do is find a way together of putting the resources in the right place. And so what we've done is we are asking you to commit to the principle that this is what we will do, that we will put resource into that front line for local people, but also that we will look at the opportunities, and Helen's brought together some options around how we might do that with the money. So one of them is a bit like we have a mental health investment standard. We put some money up front before we even think about how we then put the rest of the money into the system. But there are other opportunities. It's about maybe focusing some of our flexible funding around transformation, and it might be around prioritising within this and putting all of our resources in that way. So there's all sorts of options in here about how we do that. What we're not doing today is asking you to make a decision on exactly how we do that, but what we are asking you to do is to sign up to the principle, to sign up to the fact that we will look at those options and come back with how we will do that over the coming years. That also we will pull together a plan on what the priorities are and how we will invest in South West London in order to make this a reality. And, you know, primary care we've talked about, you know, that is a prime part of what we do. Community services, voluntary sector, how do we do things in a very different way for this ICB? So we've got a few recommendations in there for you, but I think this is an important part of what we do as an ICB. I think even my hospital colleagues will agree that actually this is really important. This they might not have done a few years ago. I think that the pressures on the acute services that we have now really have brought this to the forefront, that actually we need to do more to prevent people coming into hospital. So I'm going to just stop there and ask for, I mean, I'm happy to go through maybe them individually, but have a discussion.
We'll come to those. So I am keen to get some feedback from people on this. We're not at this point, as Sarah said, asking to commit a particular sum of money. I think there are options within here which are more attractive than others. I'm very taken with the approach, building it similar to the mental health investment standard on the basis that's programmatic. The top slicing of acute budgets actually suggests that they're the problem. Actually, if we have an investment standard around preventative and anticipatory healthcare, there is nothing to say that our trusts may not be leading or partners within the delivery of those options. And it just feels like we can actually design a flexible programme built around real facts on the ground, which we know will impact upon things that our communities need, but actually will have a direct impact upon pressure within our acute hospitals in order that we can continue to progressively release more and more funding to invest in this. So it's really important that we get our investment decision right, as well as just making that principal decision around the money. Sarah, can I bring you?
I forgot something which I should have said, because one of the other areas that we've highlighted is mental health. And the reason why we have done that is because if you look at the level of investment in South West London in mental health services in comparison to others, we are actually quite low. And what that means is, even though we have a mental health investment standard, so does everyone else. So everyone else is increasing, and they're increasing at a higher rate because it's a percentage and we invest less. So we've identified prevention, community, primary, those kind of areas, but also mental health, because we believe that's an area that we should invest in South West London, and we know it's a priority. So sorry, I did forget to mention that specifically.
If I can bring in Ruth and then Jacqueline.
Thanks, Sarah. Really good to see this. I know we've discussed it a number of times, and I don't underestimate the difficulty of doing this. So really, really good to see it. My only reflection, I think it's very clear in the paper that there's a real link to health inequalities in terms of how we want to target this, but I think it would be good to just see it under para 4 in terms of the principles to enable investment. I think we could bring it out more strongly, links to the previous discussion that we had, but really good to see, very supportive, and I know we're not making decisions, so I will stick to the brief.
Brilliant, thank you.
We're going to make a decision.
Yeah, we're going to make a decision, and we do want to get some feedback on some specific areas, but Jacqueline.
So thank you, and as an acute chief exec, well, I look after quite a bit of community as well. I absolutely support this. I think I just want to highlight one of the principles here, and actually what I would like to see is it a bit more clearer. It's not just about the baseline, it's about absolutely clear measurements of improvement, because I think part of the reason that the money goes into acute so much is because we measure it to death. So there is something about having clear measurements across mental health and community for me that means if we don't get that, we might not know whether actually money is making an improvement. I think the second thing is about how we change some of the culture, because at the minute, the only place that anyone can go at any time for anything is an acute hospital, and we can never say no. We don't say we haven't got any beds left, so you can't come in. We have to keep going. So there is something about how we all change the culture about it can't just be the acute, just we all have to be at points flexible and be able to expand. And I think we just need to also maybe think that as a principle about how we change some of the thinking that we have in organisations. The last bit actually I was going to say what Ruth said, which is the bit for me is that's great doing all of that because I think it's the right thing to do, but I think there is something about where we decide to invest in terms of improving health inequalities, because one of my strong bits, and it sort of goes along with what Matthew said as I walked in, is if we don't actually get families and children and communities working better and supporting each other and adopting different habits, we haven't actually saved anything or made anything better. So for me, there is I'd much rather, I'd like to also see a chunk of that go into that.
So I thought this would be a lively debate. So I'm going to go to
Thanks. So I hugely welcome this paper. It goes to the heart of what we ought to be achieving. We all know that we need to do more before people get to acute hospitals, and we need to do more to make it possible to move people out, and that means a shift. I get that it's important to think about exactly what metric we will use, because it needs to be sustainable. I just flag up, I read something the other day that NHS Confed did on community care, which showed some very interesting stuff, good data behind it at PCN level, about which shows a 15% return on higher investments in community care, reduced demand on acutes. It strikes me there are 4 things that are important about how we go forward when the work's been done. One's that the flow of funds is predictable, so that it creates a foundation for the cultural change that Jacqueline just mentioned. It needs to be large enough as well. That doesn't mean huge, but it needs to be large enough that it naturally factors into people's strategic thinking. Thirdly, it strikes me it's really important that we do get the data to draw the picture of return on investment in a financial way, and that needs to be, say, 3 years. But what's important about this is it needs to be, we need to measure what's swift enough to actually affect the sorts of debates we might have at national level. So 10 years doesn't do that, say 3. The last thing I'd say is we need to get ahead of the national debate. And in South West London, we're in a very good position to potentially get real advantages from what will happen over the next year or so. And that, I think, means the more we can show within 12 months that we're building a meaningful case, the better. And that points to trying to think about how we could tell a finance story in 12 months and actually have a related communication story that's intelligible to the public. Because it may be that there are really big opportunities for those ICSs that have done this work properly. So some technical bits, but I think there's a big strategic opportunity.
This certainly puts us way ahead of the thinking in other ICBs, as far as I'm aware, certainly within London, but I think nationally as well. So I think it is, potentially really groundbreaking. If I can go to Ruth next.
And I agree it's groundbreaking, and I absolutely support it. I think we're doing exactly the right thing. I just wanted to remind everyone that we are an integrated care system and that the crisis in social care is real. There is no reference, I'm not suggesting in any way that we should be trying to shore up social care. That's far too difficult and far too expensive. But we need to recognise that the crisis in social care across South West London, across the country, is real and is going to have an impact. Just so everyone is clear, there are 7 councils across the country who have issued a 114 notice. There are another 23 who are about to do so. There is a deficit of £600 million across London, which needs to be covered by the end of February because we can't run deficit budgets. And what worries me in all of this is that I'm hearing more and more, not in South West London, but in other parts of the country, that the only solution to the problem is to go back to the statutory services, and that will mean the death of preventative services. So there's a real problem in this country. We can't solve it here today, but this is a plea from me for all of us to be talking about this, to be putting it in our reports and to recognise the gravity of the situation, because this is the right thing to do, but the crisis in social care could actually undermine it.
Thank you for that, Ruth. I'll go to Joe and then to James, and then Annette.
Thank you. And just sort of building on what others have said, I think to Dick's point, it's really important that there is sort of predictability in the commitment that we're making to enable us to make some longer term decisions as opposed to revisit what we might do from one year to the next, which I think generates a bit of instability. I think we ought to be thinking about how we create the economic case for the changes that we're talking about here, not just the financial case, and certainly we've started to try and look at that locally in building the case for proactive anticipatory care, where you think about the impact of more effective prevention on not just the NHS's bottom line, but also employment, knock-on consequences for mental health and wellness, etc., for the communities that we're serving. I think the voluntary sector probably need highlighting as a place that we should consider investment. My perspective is it's easy for us to fall into the trap of engaging with the voluntary sector when we've run out of ideas. And I think if we bring them up front in our strategic thinking about how we might tackle some of the problems that we face, that would be great. And my experience is a little investment and certainty goes a hell of a long way with the voluntary sector. And then finally, I think there's something about how do we also support our unregistered carers in all of this, because they can also be really instrumental in prevention and the wellness of the communities that we serve. Thank you.
Links back to some of the things that we might want to think about, how we not fund social care but support social care and the, within this as well. So I think we put a lot of focus upon the anticipatory and preventative agenda, but there's also the reablement agenda, which equally has a financial case for us within the NHS that we might want to be factoring in. So thank you for that, Joe. James.
So it's interesting because Epsom St Helier has about a decade's experience of making active decisions now to channel investment into community services in order to offset pressures in the acute sector. And the therapy-led unit, which we're in the process of mobilising at the moment, is a community-led service on an acute site funded by a scheme, a national scheme, where actually it's about increasing overall capacity, but we've chosen to deliver it through a partnership with our community services. I think that I completely support it because we've seen it work. There are absolutely some lessons about how to make it work. It's relatively easy to write the cases. It's much more difficult to deliver them effectively, and they need a lot of senior leadership time and attention, because the sort of whole pathway collaboration that gets the benefit out of shifting this investment doesn't come automatically. It requires a lot of hard work. So I think the implementation framework, the assessment framework, how we really have that clarity and grip as we see this through is going to be absolutely critical, because the worst thing would be to shift the investment and then we slightly lose sight of whether we're getting the benefit and how we drive it out.
Thanks, James. Annette.
Thank you. As a GP, I can imagine you're probably not going to be surprised to hear that I think this is an absolutely fantastic thing to be doing and long overdue. I think it's an opportunity. We've got some time because we can't do this until a certain time period has passed. So I think we need to take some real time to consider carefully what the areas are that we want to impact. to pick some areas where we can make a significant impact. That might mean some significant changes need to come with that in how we deliver and set up services. But I think if we don't do that, we'll be missing an opportunity. I think there's also something absolutely about looking at data and being driven by evidence, and also looking at the case for putting some investment into primary and secondary prevention, and how we determine which, how we divide that up, shall we say, how we allocate what percentage of investment we're going to put into those, and then how that perhaps changes over time as we start getting on top of some of the stuff that is more pressing, and we can move more into that primary prevention over time, over a longer time horizon, and give some of this stuff time to embed. As has been said before, I think if we looking at changing impacting wider determinants of health and primary prevention, those are things that have an impact on the wider system, not just on health. And I think we do need to give that time. We need to stick with our choices that we make, that there's evidence for, and give that time to have an effect.
Fantastic, thank you. Love those ideas. Matthew.
Thanks, Chair. Just to pick up on a point that Ruth made and then link it to a point that I was going to make, the local authority financial position. I mean, we're living with that with the Section 114 in Croydon. I mean, my reflection on it is actually what it requires you to do is lean in even closer and not work away from each other, because one of the ways of addressing some of those issues is by doing transformation and integration, because it can actually help in terms of improving services, but also improving efficiencies and trying to help the issues around the 114. So I think that is an important part, and it sort of links to one of the points in the table under the section on options for releasing funds, where it talks about reductions from the acute contract to play into community. And I note that's not for recommendation now for obvious reasons, because of the challenges we've been talking about earlier today. But at some point, that question has to be answered, because if it doesn't, how it's been thus far will likely continue, and that will be a continued investment in one aspect and not enough on the other. So I think there is some learning to be reached from that, but I completely agree with what's in the paper. Doing it at the moment in the acute set by reducing that in the climate that we've just been talking through earlier today probably wouldn't work, but at some point we're going to have to get to that.
Well, I'm going to get Sarah to close this in a second, but Alicia, I know that you wanted to come in.
Thank you. I just wanted to say that HealthWatch is very supportive of this principle, and all three of the areas highlighted are areas where we've heard a lot from patients that things really need to change. I just wanted to say, I know that we've been talking a lot about making evidence-based decision-making, both in terms of the specifics of how this investment will be made and monitoring the outcomes and impacts. I just wanted to highlight that to include qualitative data in addition to the quantitative, I think sometimes that's overlooked. HealthWatch has a repository of information. Of course, Charlotte Gaughan's team has a lot of work in this area, and just wanted to highlight that. Thank you.
Thank you for that, thanks. Nicola.
Yeah, thank you. So I absolutely welcome this. I've been using the term primary care investment standard for some time, so I think this actually goes beyond that, and I think that's really positive. It's such an important commitment from this board to be hearing. But, we really shouldn't underestimate the challenge of doing this, particularly in the current financial environment. This is easy to do when you've got plenty of money, isn't it? And actually we don't, so that's a really significant issue. And I think there's something about the sort of balance and scope. So, doing some high impact things in local areas, population services, seems like a really important thing to do. But actually, I think what we know is the whole sector needs to be up-funded in order to really have an impact. And that's less easy to describe the impact, actually. So it's going to be really, really interesting work. I'm really looking forward to our conversations on this.
Fantastic. It seems like that the enthusiasm in the room. This is an ICB board, guys. It's sort of calm down. It's fantastic. It's absolutely fantastic to see. So, Sarah, please sort of feel free to conclude this.
So, firstly, as accountable officer, obviously I'm concerned about the money. But my experience is that if we wait until we are in a situation in the NHS where we've got enough money to do this, we will never do it, which is where we've got to now. So we have to take the leap, is my view, because otherwise we will not do this. So we are going to have to really think about that carefully as a board, how we manage risk and how we make those decisions. So, you know, the commitment is not a small commitment that we are asking for today. Secondly, to come back on Matthew's point, I think you're absolutely right. At some point we should think about, you know, if it's reducing spend in acutes, then how do we take that? However, if we start off with, we're going to take it out of acutes in order, that is where it's failed in the past. I still sit in meetings now with national ICB colleagues where they say, how are you going to get the money out of the acutes? And I said, I'm not going to. We're going to put the money up front so that actually it helps to make the whole system run smoothly, and then we might reduce growth over a period of years. That's the kind of way you have to work in the NHS. We learnt a lot through the mental health investment standard. We've got to take a different view. So I'm really enthused by your enthusiasm. This is a leadership challenge for all of us. We've got the right people around the room to make this a reality, and we've all got to stick by that, even in difficult times, would be my view. I'm taking on board all of the comments, and again, thanks to Helen and Tonya who have helped pull this together, and they will, you know, they'll be working to help us on how we take this forward in the future. Really important that we get the data, we shouldn't sometimes we wait too long for the data in the NHS, I would say. We need enough data to be able to make a decision, but we also need to be able to evidence what we do. So we need to make sure we can do that. I've written everything down that you've said, so I'm not going to repeat it, but I think thank you very much, and now we all need to commit, don't we?
Fantastic, thank you. So we'll conclude that section. We're going to take a comfort break now, and I suggest, because we're running just a couple of minutes over, that we come back at 5 to 12. Okay, folks, we're going to make a start again. And if you don't come back to your seats very, very quickly, I'll make this meeting last for ages.
Hold on, James. There's a surprise.
Okay, welcome back, everybody. We're going to move on to item 10, and if I could ask Mark to talk us through the Primary Care Access Recovery Plan.
Thanks, Chair. Just to say that as part of the Primary Care Access Recovery Plan, we are asked to bring an update to the board around this time of the year, and this is ahead of a kind of deep dive primary care session at both seminar and back at the board. So I'm going to be relatively brief in terms of the update, but just to say that I think across the board we really have made some excellent progress in terms of delivering what the plan has asked us to. We have really promoted NHS app, and we have 95% of our practices now have got their records on the app, so people can access their records. We've also got 99% offering repeat prescriptions on the NHS app, and there is a comms winter campaign to really promote the use of the NHS app. So I think South West London are kind of doing very well there. Other areas that we just wanted to point out was around kind of making sure that general practice websites are up to date, that they have the right information on them, and there's been a piece of work across all practices. And also that we've now got 100% of our practices offering online consultations. We've still got 65 practices that are on not on cloud-based telephony, so that's a plan between now and April. But they all do have access to things like online consultation tools and digital support coordinators that are going through every practice in every borough. Just picking up on James's comments earlier around primary care capacity. So we have a number of training schemes, including things like GP fellowships, to ensure that our primary care cohort is both, we're building on it, but also it is trained appropriately. And just in terms of equity as well, we've recently done an LGBT kind of session with practices in Merton, and that's going to be rolled out across the board. I think one of the challenges is to link it to the HIV work that we've also just heard about at the beginning of the session. One of the areas that we do want to just focus on is that we have the ARRS roles, and we are planning to have 845 new roles across South West London, which is a really significant increase in our kind of working capacity. But we do need to really make sure that we know what they're doing, when they're doing it, and that it's driven by our primary care colleagues to ensure that we're joining that up across the board. Finally, I just wanted to say one piece of work that we want to continue and develop is the reducing bureaucracy. So we know that the secondary care, the acute trusts are doing a lot around recalls, fit notes, onward referrals within trusts, but we want to work with them in that pathway between primary and secondary care. So one of the things that we're establishing is a kind of working group to really make sure that the interface on those pathways is as strong as possible. And so that's kind of where we're at the moment, but we will be bringing a more deep dive to a future board.
Thank you for that update. Are there any points? Nicola, I'm looking at you. I thought you might have some point.
Yeah, thank you, if I may. So I think there's some really great work going on in practices and PCNs and federations with really good support from the South West London primary care team and local place teams as well. But I just wanted to sort of raise three issues really, more comments than questions. So you know, we're working in a system at the moment where there are some real tensions and risks. And at the previous board meeting when we talked about primary care, we talked about the workforce challenges, the estate and the IT issues, which really kind of hamper progress at times, increasingly financial challenges too. And this paper cites no particular risks with delivery of the initiatives that we're working on because they're being well managed. But I just would encourage the board to consider you know, the other kinds of the broader risks that we have in general practice at the moment and in wider primary care as well. Secondly, this is a very specific requirement to deliver on the primary care recovery plan, so it's just a slice really of what we're doing. And our wider South West London strategy encourages to focus on prevention and proactive care as well as access. There are some, you know, really powerful drivers in the system which are focusing us all on access, but I really think we should try and keep that balance because that will be better for the future delivery of these services. And then Mark flagged that the interface element of this is really important, and I think you know, the paper describes more about the territory that we need to address rather than the things that are in place. I think this is a lot for future work, and that interface between primary and secondary care it's really where care can be disrupted, and it's where pathways can break down, and it's where inefficiencies can be created. So I think we've got work to do to make sure that, among other work streams, the outpatient transformation work is designed not only to reduce bureaucracy, which would really help, but to ensure that care's more joined up and safe at that interface. And this is where we need real system working. So we've got an opportunity with this to get primary and secondary care together and to crack these issues in a way that our patients and our workforce will really benefit and appreciate. Thank you.
Nicola, thank you for that wider context as well. I think really important to remember. Are there any other points that people would like to make? Jacqueline, sorry.
Can I just ask you and your colleague a question about how is it feeling in primary care? Does it still feel as tough as it has done? Do you feel that with organising some of this, helping patients a bit more through the NHS app, it's actually making a difference for your working lives as much as it is for patient access?
So I think there are things that are happening that are definitely making a difference, but it's rough.
So, Jacqueline, and I'm going to speak from my practice. I think one of the best things we did was move to a total triage system. And I know that's not easy for all practices. It wasn't easy for us, actually. It took us 6 months and we lost staff doing it. But we have trained up and hired new staff. And I think it has been a revelation to know actually what your demand consists of on the day, so that you can plan your capacity and plan how you direct patients and the concerns that they're coming with to the right people. But I think that's a really big exercise to undertake, and I think we have to be patient. I think more practices are moving towards that model. I think that is part of the answer, but it's very disruptive. And it is quite difficult, and considering we don't have a lot of management capacity in primary care, it's quite an ambitious thing to do. But I think that, and together with some of the other digital support like the NHS app, so we've got quite an elderly patient population, but 84% of our patients are registered with the NHS app. So I think, that's really positive, and I think there are a lot more solutions that can come through the NHS app still. So I think it is very busy. It is tough in primary care at the moment, but I think there are things that are changing slowly. Yeah.
Thanks, Jacqueline. Thanks for asking that question. I think that was really helpful. Annette, when I come down to visit, I'd really like to see how that operates. Just as a point of interest to colleagues, I'm chairing for NHS England the deliberative inquiry into the future of primary care in London. So we'll feed that in, but it would be useful to get some good examples. Mark, did you want to say anything? Were you leaning forward for... No. Just moving away from the radiator because you're too hot. Thanks very much. So we'll move on to the next item on the agenda, which is Ruth. It'd be great to hear an update from the Integrated Care Partnership.
Thanks. And you've got the report, so I'll take it as read. I'm really impressed by the commitment of people who are working so hard on the 6 different work streams. There was a feeling that this is on top of the day job. I think increasingly it's being seen as part of the day job, and I think that's a really welcome step forward. But the 6 work streams are now up and running, a lot of work being done, and I'm looking forward to getting some progress reports from all of them. What I would say is that having listened to the various discussions this morning and going back to what I said about social care, I just think it's so important that there is a place where we can talk about these bigger, more strategic issues. I do think there is a real risk with the financial constraints, the workforce pressures that we're all seeing. There's a real risk that we could end up with just thinking about how to keep the lights on. It's important that we have an opportunity to look about these overarching, underpinning these big issues that actually will make such a difference, and then think, and this will be the challenge, about how we can integrate all of that into everything that we're doing. We had the beginning of that discussion with health equity, and I think it's important that we look at all the 6 work streams and think about how we can integrate it across everything that's happening. I'm going to give a special shout out, if I may, to Sarah and Elisa, because the work that they're doing, representing such diverse places and communities and groups, is absolutely extraordinary. They're ensuring that not only there is a voice for our community, but also that they are ensuring that the challenge is coming at the right time in the right place, so that it's able to make a real difference. And I just flag up the fact that to have an event to talk about Health Inequalities Fund and how the applications could be made, and to have over 250 different people and groups coming along is absolutely extraordinary. And I think just shows the level of engagement that's happening across our area. So I'm really impressed by the work that's happening. I'd like to thank everyone that's involved, but we also recognise there's a huge amount of work still to be done. And I hope there will be more opportunities that the work that we're doing on the partnership board will feed more directly into the work that's happening here. Thanks.
Thank you, Ruth. Unless there's any questions on the ICP report, Sarah.
Sorry, just a quick comment. So my comment is on the Health Inequalities Fund, particularly the groups that applied for extension of the program, basically. And John kindly came to our leadership group of the Alliance was it last week, I think, or the week before, and we discussed this just with reference to some of the challenges that, in particular in Sutton and Kingston, the voluntary sector groups applying for extension went through. I just wanted to highlight it because it was really a struggle for them. Particularly when it comes to the budget, basically, and the clarity on how the money could be spent if the delivery was to be in 2023-24 or 24-25, and it wasn't clarified until literally the last hour when it comes to applying for the budget. And I know it kind of sounds dramatic, I guess, and probably not particularly important, but I think what is maybe a butterfly, flapping their wings in, a big organization like the NHS. It's a tsunami in the voluntary sector. And so my reflection, and we were talking to John, obviously, about the learning and how difficult it is within the NHS financial and budgeting processes to have a system that is not kind of last minute or is perfectly clear. We perfectly understand that it's not possible. But I was thinking going forward, if we really want the voluntary sector to be involved, we want that prevention, we want the innovation, we probably need to think how can we maybe better communicate with the sector at the right time to make sure that, we know where we stand. Some, in some boroughs it happened, the clarity was there, in others it didn't, so there must be some learning that we can move from one borough to another and just make it, I think it's a cultural change as well on both sides to kind of understand how we work and what impact things can have in both realities. Just wanted to mention that.
Thank you, and I'm sure John will take that on board as we think about the Inequalities Fund moving forward and our other funds. Thank you. We'll move on to committee reports now. For these, we get them introduced by our committee chairs, and then a bit more detail coming from the executive sponsor for that committee. So if we can go to finance first of all, Dick.
Thanks, Mike. Just briefly, met at the end of September, 2 deep dives as usual. Very good to hear about the Mental Health Collaborative building over 7 years, a really strong programme and a lot of self-confidence. Kingston and Richmond Place, proactive anticipatory care and integrated neighbourhood teams, interesting parts and relevant to our earlier conversation. Continuing healthcare issues, that issue of assessment brought home to the committee, and then just on finance that Helen will speak on in more detail. Good progress, but still the issue of too much non-recurrent saving and not enough recurrent saving. The need for us to push on transformation, and of course our earlier discussion shows how much more difficult that's just become.
Thank you, Dick. If I go to Helen now.
Thank you, Chair. So within the pack is the month 6 finance report, which effectively shows the ICS system on plan except for additional industrial action costs and loss of income due to loss of activity due to industrial action, which has been held equal and opposite within the ICB position. Within this pack, we continue to forecast that we will deliver our £82 million deficit plan. And I continue to work, so I'm continuing to work to develop the efficiency plans to be able to deliver them, recognising the challenge that Dick has just outlined in where we go. I'm happy to take any questions on it.
Thank you, Helen. Are there any questions for Helen? Thank you. So we'll move on to quality and oversight. And if I could ask Mercy as the non-executive chair of the committee.
Yes, I'll just introduce this. Obviously, we always get an update on the Care Quality Commission if they've done any inspections across South West London, and we'll receive some as the board is aware. As we've been talking about today, the maternity programme and local maternity neonatal services, we did a deep dive into that as well. we often have annual reports across the system, and this time it was a child death overview panel, which are chaired kind of locally by independent chairs, and came to our committee just to see what's going on in South West London. I didn't particularly want to raise any other issues. I'm sure Elaine and John and Jonathan might want to talk about performance and quality, but we received kind of regular updates on how the system is doing.
Thank you, Mercy. I'll go straight to Elaine.
Thank you, Chair. Yes, I think we talked about performance, and we've talked a lot today about some of the challenges around 45-minute handover and some of the quality risks for the urgent emergency care pathway across South West London, and committee agreed that it would regularly look at that performance and the quality impacts and patient safety, patient experience impacts of that. I think it's probably timely to say we're just looking at the terms of reference of the Quality Oversight Committee again at the moment, and that's part of a piece of work that I've been doing with my team in terms of our quality assurance and quality governance within my directorate. I'm really pleased to say that the team have really engaged quite enthusiastically with that, how we move forwards in terms of our assurances, and so that we're taking the right information, the right papers for the right discussions at Quality Oversight Committee. This week we had a dummy run of an operational quality management meeting to test out some terms of references and work through how our proposed quality governance structures will work through, to be able to discuss that with SMT colleagues and take forward, and how that will then feed into the Quality Overview Committee. I think Mercy had agreed that we would bring that piece of work back in February's Quality Committee with some recommendations of how that works. So it's quite exciting.
Thank you. Any questions for Elaine? Jonathan, performance.
Thank you very much. So obviously take the report as read, but just to highlight a couple of areas. So it was really good to see the recovery in our performance around childhood immunisation, which normally is the best in London, and return to that status. So there's a lot of work gone into that. We continue, despite all the challenges of industrial action, to hold up the best cancer performance in London in many areas. So it's I want to call that out. And also to note, despite the major issues and challenges presented, mental health 12-hour waits for patients, which obviously has a profound impact for them, is for the reporting period, which is till September, October time, is the best it's been since the spring. So it was good to see that improvement in position, notwithstanding the level of challenges we face. And then turning to those, in a number of instances we've already talked about the challenges of the urgent emergency care pathway. Elaine just mentioned the ambulance handover piece. But to note, progress in two ends of the pathway, in a very long ambulance wait. We're seeing a reduction at this point in time. And also to update the paper that's in that presented to the board, we've also seen progress on virtual wards at the other end of the care pathway for urgent emergency care, now in the mid-60s in terms of utilisation, which is good to see. However, the challenges we're all aware well of and spend many hours every day addressing around long waits for patients in the emergency department remains there, and is a key issue for us from a quality, safety and delivery point of view for this winter. And then the other one I'd probably call out, again very strongly correlated with the industrial action we've seen, is whilst we still deliver some of the best access to elective and planned care in the country, the number of patients waiting long periods of time, currently the 65-week metric is the one we're looking at, is double where we plan to be, driven by the industrial action, and we have plans to get that back assuming industrial action is abated somewhat over the coming months. So those would be the areas I wish to highlight as sort of strengths and challenges.
Really good to hear, thank you. Any questions for Jonathan? We'll move on to audit. Martin.
Thank you. So the Audit Committee met on the 24th of October. We reviewed the Strategic Risk Register as we usually do. There's nothing on the Risk Register that the Board is not aware of. We're continuing to develop the Risk Register and Board Assurance framework so that we map onto our strategic risks, our risk appetite and risk tolerance, and we can track where we're outside of our risk tolerance and report that back to the Board. We specifically looked at our cyber security plan in the light of the NHS cyber security strategy and our implementation of cyber security plans. Actually, at the same meeting, we received an internal audit report on our approach to cyber security, which received a substantial opinion from our internal auditors, which was good to see, given the evolving threat that cybersecurity is. We also got from the internal auditors a report on our handling of individual funding requests, and that was a substantial opinion as well, which was good to see. In terms of external audit, we looked at the audit plan with our auditors, Grant Thornton, for the year that we're in at the moment, 23-24, and got an assurance from Grant Thornton of their ability to carry out that plan, which is good given the pressure that there is in the audit market at the moment. We got the final report from last year from Grant Thornton, which included an observation about financial sustainability, which they were obliged to make because we're an ICS in deficit, but that closed out the audit report for last year. And I think those were the main points.
Thank you, Martin. Any points to add to that? James.
Thank you. I just wondered if the Audit Committee had assurance on the capacity and resources required to bring down the number of single tender waivers, because I think that the procurement and contracting capacity is a constraint across the system at the moment, and I think it's a risk to us in terms of both compliance but also delivering efficiencies, not just in the ICB but actually across the system.
So we did look at single tender waivers. So the single tender waivers individually go through the Finance Committee. What we look at in the Audit Committee is the pattern and the trend of the number and value of single tender waivers that go through. I don't have the numbers in front of me. It's declining. So there has been, I think, so going back 6 months, there was a bit of a bulge because we wanted to we needed to get through a number of single tender waivers that were urgent. From that point, the number of single tender waivers is declining, but it's something we'll continue to monitor.
Thank you for that. John.
So just say really helpful to observe that there was a conversation about cybersecurity at Audit Committee. It's really important for the team. And Martin, just to pick up on the word you used, the evolving threat, because that is the nail on the head. And as good as it is to have an assurance report, Martin and I, the rest of the team, and I'm sure many people who are running service are conscious that it's a bit like whack-a-mole, and as one threat is sorted out, the next one emerges. So I think this is something we need to continue to keep going back to in operational circles as well as board circles, because it's a significant risk to ongoing provision of services, and I'm sure we're all aware of that. So thank you.
Thank you, John. Any further points? No? Okay, we'll move on to any other business, and I've not... Chief Exec's report. Oh, sorry, Chief Exec's report. I forgot. I forgot I had one of those.
Thank you, Chair. It's good to know I'm not forgotten. So I will take most of the report as read, but I did want to highlight a couple of areas, if that's okay, Chair. Firstly, just on the RAC, the reinforced autoclaved aerated concrete, because I know the board did ask, did we have any in South West London? I mean, we can't say absolute, because there might be a bit out there in some GP practice that we don't know about, but we have done a review, and as far as we know, we have no RAC. I do think it's really important to say that even though we don't have any of the kind of media-friendly RAC, we do have significant infrastructure problems across South West London in both general practice and in some of our hospitals, in particular Epsom St Helier. So I just wanted to say, you know, RAC is important, but actually infrastructure as a whole is very important to us in South West London and capital in order to put that right. So I just thought I would mention that one. The other one I wanted to highlight was the annual emergency. I've got a whole load of acronyms here. EPRR, the Emergency Preparedness, Resilience and Response. Really important because as a new ICB, we are now a Category 1 responder, which we weren't when we were CCGs in the past. And well done to the team because they've had substantially compliant in the new EPRR assessment around our ability to be able to fulfil our requirements. I wanted to mention that we have now closed our staff consultation around the management cost reductions. We will now be taking forward our response to that consultation in the next week, and we will be hopefully implementing, well, not hopefully, we will be implementing before the 1st of April next year, and we will keep the board updated with progress on that. And finally, just an additional item, which you may have seen in the press yesterday, is that nationally they have announced that they have awarded a contract on the Federated Data Platform, the National Federated Data Platform. I know there is noise around this. I have personally seen a demonstration of this platform. I think it will be a real benefit to us in South West London. My biggest concern is that we won't have it rolled out quick enough because I think we would like to see it as quickly as possible in South West London. We think it will achieve benefits both in hospitals, in primary care, around how we join up our data, how we do things like our system control centre across South West London. There are huge opportunities within this federated data platform. It is a huge amount of money, but actually if you split that across the whole of the NHS, actually per organisation it's quite a small amount in comparison. If we'd have all each individually gone and bought this, this would have cost us a huge amount more. So I do think we need to look forward to the potential for the new federated data platform, and my only concern is can we have it sooner, really, I think would be my comment on that. Thank you, Chair.
Great. I think really important to highlight that. For those of you who are trust chairs, trust chief executives, please do remind your chairs that the London Chairs meeting on Thursday, tomorrow, has a significant, substantial feature on the federated data platform. We thought it would be useful to bring them up to speed on the whole of the programme. Now we come to any other business. Is there any other business? I've not been notified in advance, so I'm assuming that there isn't. No, can't see any hands going up. That's because they're frozen by your sides. We'll actually formally close this part of the meeting now, and we will move on to questions from members of the public. I've not been notified of any questions from the public, but I can see, I think it's Wendy, isn't it? Yeah, Wendy, you would like to ask a question, so we'll make sure you've got a microphone.
My name's Wendy Micklewright. I hallucinate, I hear voices, I'm not ill, I don't take psychiatric drugs, I'm involved with the Hearing Voices Network, and I'm involved with the community group that gets no official funding. I was watching yesterday a podcast because I'm covered under the Equity Act. I'm in fact dyslexic. And that podcast was from the UN and the World Health Organization. Given watching this meeting and comparing it with their meeting, it was very interesting how they presented information and how they listened and how they learned and what their culture was like. And basically, they've come to an agreement that there should be an end to coercive mental health treatment. So if we look at again as an example from freedom of information, we know that most people who receive ECT don't consent. We know that obviously restraints, seclusions, and forced medication are coercive practices. And as I've mentioned before, the petition for the stopping of electroconvulsive treatment is now over 134,000 people. So there is a complete mismatch, I think, between organisations like this and the reality on the ground. And we do know as well from research that many people, it's known as the medicalisation of distress, and many people in the mental health system actually are homeless. And I think we need an end to what's known as wealth supremacy, and I would recommend you look at information about that. Thank you.
Wendy, as ever, thank you for your thought-provoking comments. We will make sure that we reflect upon those areas, and if you could provide us with the reference on the final piece, that would be really helpful to allow us to look into that. Thank you. Are there any other questions from anybody here? In which case, I'll bring the meeting, this part of the meeting, to a close as well. So thank you all very, very much. There will be sandwiches. I was going to say hot food. I think it's unlikely. There'll be chilled food available in the middle hall for the board.